Everyone, I welcome you all for today's webinar on Oncology Frontier Navigating Lung, Breast, GI, and GU Cancer. With immense pleasure, I would like to invite Dr. Pyanshu Chaudhary, Senior Consultant Medical Oncology, Livasa Hospital, Mohali, for the welcome and introductory note. The stage is all yours, sir.
Thank you, and I'll welcome all participants for this two-day event. So we all know that oncology is rapidly evolving, and it is very difficult to, remain updated. So we'll be discussing over two-day event various cancers which we deal in our daily practice, and we'll be covering the main cancer, that is lung, breast, GI, and GU. We'll be discussing uh, current practices, recent advances, as well as some, breaking abstracts which we'll be presenting. So these are our academic partners, and I think for the first talk, I would like to welcome Dr. Mukesh Bansal, who is a consultant medical oncology at Alchemist Hospital, Panchkula, and over to you, Dr. Mukesh, for your first talk.
Yeah. Good evening, everyone. First of all, I congratulate Dr. Pranshu Chaudhary for hosting what looks to be a very wonderful scientific academic conference. So, as an opening batsman, I have been the task given to speak on a very interesting new trial, TELA-PRO 2, which is the phase 3 trial of first-line talazoparib, which is a PARP inhibitor, plus enzalutamide, which we know as an androgen receptor signaling inhibitor in metastatic CRPC patients. Next slide, please. Next slide. Next slide. Yeah. So enzalutamide, as we know, androgen receptor signaling inhibitor is standard of care for metastatic CRPC patients. Talazoparib is a potent PARP inhibitor which prevents DNA repair. We have the phase 2 TELA-PRO 1 trial which showed durable anti-tumor activity and manageable safety of talazoparib monotherapy in heavily pretreated metastatic CRPC with HRR gene alterations. So with this background, it was hypothesized that if we combine the PARP inhibitor and ARSI combination, it can be used to improve PARP inhibitor efficacy in tumors without HRR gene alterations also. So taking forward this, TELA-PRO 2 was designed. It is a phase 3 trial which evaluated talazoparib plus enzalutamide in patients with metastatic CRPC unselected for HRR status. Next slide. So the study design was patients with newly diagnosed, it was a double-blind randomized placebo-controlled phase 3 trial with newly diagnosed metastatic CRPC patient, ECOG performance status 0 and 1. Samples were prospectively assessed for HRR gene alterations. Total 805 patients were taken. Stratification was done by prior abiraterone use, prior docetaxel use for CSPC status, HRR gene status. It could be either deficient or non-deficient or unknown. HRR gene alterations like BRCA1, BRCA2, PAL2, ATM, ATR, these were included. First arm was given talazoparib 0.5 mg OD plus enzalutamide in the standard dose of 160 mg OD, 402 patients, and in the other arm, placebo plus enzalutamide in the standard dose of 160 mg OD, 403 patients were taken. So the primary endpoint was response, progression-free survival by Becker analysis. Key secondary endpoint was overall survival, and other secondary endpoints were time to cytotoxic chemotherapy, PFS2, overall response rate, and safety data. Next slide, please. So the baseline characteristics were quite similar. Median age was 71 years. Median PSA was 18 and 16. 80, around 85, 86% of the patients had bone mets in both the subgroups. 36% patients had lymph node mets in the talazoparib group and 41% in the placebo group. Lung mets were there in 11 and 15% of the patients, and liver mets were rare. Were 3 to 4% of the patients had liver mets. So ECOG performance status 0 and 1, both were equal, both were well represented. 64% of 2/3 of the patients had PS0 and 1/3 of the patients had PS1. So prior abiraterone use was there in 5 to 6% of the patient, while around 1/5 of the patients had prior docetaxel use. HRR deficient, around 1/5 of the patient were HRR deficient, and majority of the patients, close to 80%, were HRR non-deficient or unknown. Next slide, please. So coming to the survival outcomes, median PFS by Baker in the combination subgroup is not yet reached, while in the placebo it is 21.9 months, while the hazard ratio is 0.63 with the significant p-value. So median PFS by HRR status in the HRR deficient subgroup, it is 27.9 months in the talazoparib subgroup versus 16.4 months in the placebo subgroup, giving a benefit of around 11 to 12 months or close to 1 year with a very good HR of 0.46 and a significant p-value. In the HRR non-deficient or unknown subgroup, the hazard ratio is 0.70. In the placebo subgroup, it is 22.5 months, while in the talazoparib, it is not yet reached. So the median overall survival is 36.4 months in the combination compared. It is not yet reached in the placebo subgroup, but the hazard ratio is 0.89. So there is a consistent PFS benefit with talazoparib was seen in all pre-specified subgroups, including age, ECOG performance status, Gleason score, stage at diagnosis, metastatic sites, or prior abiraterone or docetaxel uses. Next slide. So, patient-reported quality of life and other outcomes. So, time to PSA progression was 26.7 months in the talazoparib subgroup compared to 17.5 in the placebo. Time to cytotoxic chemotherapy is not yet reached, but the hazard ratio is 0.49. Time to PFS2 is almost similar, close to 3 years in both the subgroups. Coming to the overall response rate, 62% of the patients in the talazoparib subgroup responded compared to 43% in the placebo subgroup. So best objective response, 37.5% of the patients had a complete response in the talazoparib subgroup compared to only 18% in the placebo. Partial responses were close to 24 to 25% in both the subgroups. Stable disease was there in another 28 to 30% of the patients. Only 5.8% of the patients progressed in the talazoparib subgroup, while 22.7% patients progressed in the placebo subgroup. Next slide. So coming to the safety data, any adverse treatment-related adverse events were there in close to 89% patients in talazoparib, while 69% in placebo. But serious treatment-related adverse events were there only in 19% of the patients in talazoparib subgroup, but only 3% in the placebo subgroup. So coming to grade 3, grade 4 side effects, 70% in talazoparib versus 40% in the placebo subgroup. Dose interruption of talazoparib or placebo due to adverse events, 75% of the patients in talazoparib, only 23% in placebo. Dose reduction due to adverse event, 56 versus 7% of the patient. Discontinuation 19.1% versus 12%. So there were some more incidents of side effects in the talazoparib subgroups. Median relative dose intensity remained in more than 80% in dose reduced patients. Most common treatment related adverse events leading to dose reduction were myelosuppression and in the form of anemia, neutropenia, and thrombocytopenia. So this side effect needs to be carefully watched for in the talazoparib subgroup. Next slide. So as we discussed, the most common side effects are myelosuppression, anemia, neutropenia, fatigue, thrombocytopenia, leukopenia, while some of the patients had nausea and decreased appetite. But most of the side effects were grade 1, grade 2. Some of the side effects were grade 3. Very rarely patients had side effect of grade 4. Next slide. One case of MDS was reported during the safety protocol, which is a major concern, even linked to olaparib also. But there was only one case that was linked to talazoparib used. So the investigators' conclusions were talazoparib plus enzalutamide significantly improved PFS compared with placebo plus enzalutamide in first-line metastatic CRC. Clinically meaningful PFS improvement in both all-comers population and pre-specified subgroups. Talazoparib showed benefit in patients with and without HRR gene alterations. Safety profile of combination consistent with individual agent profiles, with treatment-related adverse events manageable through dose modifications and supportive care. Investigators concluded that primary analysis supports use of talazoparib plus enzalutamide as first-line therapy for patients with metastatic CRPC, regardless of HRR gene mutation status. Next. Thank you.
Thank you, Dr. Mukesh. And do you think if we have the availability, would you be inclined to use talazoparib along with enzalutamide? I mean, it
I
looks like
think,
from this.
yeah, I think we have very good agents for CSPC, but when it comes to CRPC, we have mainly chemotherapy till now, and there are many patients who are either not fit for chemotherapy or they are not willing for chemotherapy due to the fear of it. Those patients we can manage with the this combination. We can look forward to this is the initial data, but we can look forward to this data.
Yes, definitely, definitely. I think oral therapy everybody prefers.
Yeah.
So thank you so much, Dr. Mukesh.
Thank you.
Vishal, are you there? Can you introduce the next speaker?
For the next talk, I would like to invite Dr. Kanika Sharma. Ma'am, are you there?
Yeah, good evening, everyone.
Good evening, Dr. Kanika. Welcome. I think there has been some change in the schedule because of Dr. Praveen Jain being a little bit late. So we'll continue with you first.
Sure.
Over to you.
So are my slides visible?
Yes.
Okay. Yeah, so good evening, everyone, and thank you for inviting me. So I'll be discussing about the Checkmate 274 data, that is the adjuvant nivolumab for high-risk bladder cancer. We'll be discussing about the DFS and the OS benefit with the adjuvant nivolumab. So this was initially published in NEGM in 2021. So just giving a brief background. So it is a phase 3 multicentric randomized trial that have evaluated adjuvant nivolumab versus placebo in patients with high-risk muscle-invasive urothelial cancer following radical resection. So in this, they have evaluated nivolumab versus placebo. Nivolumab was given in the dose of 240 mg every 2 weekly for 1 year. And the primary endpoints were disease-free survival in intention to treat population and in patients who have a PDL1 of more than 1%. And they have used the platform 288 Pharma DX Dato platform. For the secondary endpoints, they have seen the non-urothelial recurrence-free survival, overall survival, disease-free survival, again divided into two populations, that is the intention to treat and the PDL1 of more than equal to 1%. So the other exploratory endpoint include the distant metastasis-free survival, the safety, and the side effect profile. So they have taken all the patients with urothelial carcinoma, that is patients who were originating in the bladder, ureter, or the renal pelvis. So after radical surgery, that is the R0 resection with negative surgical margin, they have randomized within 120 days before randomization. Surgery should have been done. There should be no evidence of disease in the 4 weeks prior to randomization. The patient can receive cisplatin-based or without cisplatin-based neoadjuvant chemotherapy with a preserved performance status. So they have defined high risk of recurrence as patients who have T3, T2 to T4A or node positive disease even after receiving neoadjuvant chemotherapy, or patients who have undergone upfront surgery. In that, patients who have T3, T4 or node positive patients who have not received cisplatin. So all of these patients, they will have defined as high risk. So they have enrolled patients with upper tract urinary urothelial carcinoma, but it was capped at 20%. So they have actually enrolled patients from 156 sites in 29 countries all across the world, from the America, Europe, Asia, and Australia. A total of 709 patients were included in this trial, which were evenly distributed between the nivolumab and the placebo arm. Out of these patients who have a PDL1 positive status, as in more than 1%, so out of 709, 282 patients have PDL1 more than 1%, in which equally 140 patients received nivolumab and 142 were kept on the placebo arm. Node positive patients, so around 50% of the patients, they were node positive. And again, 43% of the patients, they have received prior cisplatin-based neoadjuvant chemotherapy. So the median follow-up for these patients were 20.9 months in the nivolumab arm and the 19.5 months in the placebo arm. So coming to the baseline characteristics, so the median age that they have taken is around 65 years of age, with more of around 75% of the patients being male. All of them, they have a preserved performance status of 0 and 1. Hardly 2% of the patients, they were of performance status 2. Again, because it was capped, so 80% of the patients were from the bladder origin and the rest of them from the renal, pelvis and the ureter. As discussed previously, 40% of the patients, they have a positive PD-L1 expression, and in 43% of the patients, they have received previous neoadjuvant cisplatin-based therapy. So most of the patients, they were high risk, that is either upfront, they have T3, T4 disease or node positive disease was there. And when we talk about the pathological tumor stage at resection, again, the most of the patients, they have T3 and T4 A disease status. So coming to the results, when we talk about the disease-free survival in the intention to treat arm, there was a significant difference, as we can see, and the graph was separated even after a prolonged follow-up of these patients. So at 6 months, it was 75% versus 60%, the disease-free survival. And even at 12 months, the benefit was evident, that is 62.8% versus 46%. So when we talk about the subgroup that they have taken, that is the PD-L1 positive, in that there was even a bigger difference we can see with the nivolumab versus placebo. So the disease-free survival at 6 months was 75 versus 55, and at 12 months it was 67 versus 46%. So there was a significant benefit in the patients who have a PD-L1 positive status. Coming to the non-urothelial tract recurrence-free survival, in the intention to treat arm, the median recurrence-free survival was 22.9 months versus 13.7 months. And at 6 months, it was 77 versus 62.7%. And in the PD-L1, more than 1% of the group, it was 75.3% versus 56.7%. So coming to the subgroup analysis, when we see the forest plot, we can see the patients who have a urinary bladder tumor, who have previously received cisplatin-based therapy, and then the patients who have a PD-L1 expression positivity at baseline. So they have a significant benefit as compared to the placebo arm, and these patients can be considered for the adjuvant nivolumab-based therapy. So coming to the treatment-related adverse effect, the median duration of exposure was 8.8 months in the nivolumab and the 8.2 months in the placebo arm. And the most common reason for discontinuation was disease recurrence. As we know, the urinary bladder tumors, they are aggressive tumor, and even on treatment, most of our patients, they progress during treatment. So the adverse event relating to discontinuation is of 12.8% in the nivolumab and 2% in the placebo arm. And the most common side effect is the pneumonitis, that is seen in the 1.7% of the patient, rash in 1.1%, colitis 0.9%, and increased ALT in 0.9%. So when we talk about the grade 3 and 4 adverse effect, it was seen in 17.9% versus 7.2%. So as seen in this table also, the most common being the pruritus, fatigue, diarrhea, rash that was seen. And in our clinic also, these are the most common side effects that we see with immunotherapy. So coming to the expanded efficacy from Checkmate 274. So even in the extended follow-up, up to 3 years follow-up, there was an updated DFS and interim OS that have shown that there is a consistent DFS benefit with nivolumab versus placebo in both intention to treat and PD-L1 more than equal to 1% population. OS benefit with nivolumab in both the arms, the hazard ratio was 0.76 and 0.56. And there was a continuous benefit in the non-urothelial tract recurrence-free survival and the distant metastasis-free survival. That was seen in both the groups of the patients, and the exploratory analysis of these patients, they also showed a continued benefit. So when we see the updated DFS, again, in the intention to treat arm, it was 22 versus 10.9 months. That is almost doubling of the data is seen. And in the PDL1 more than equal to 1%, it was 52.6 versus 8.4 months. So we can see at 3 years, the DFS in percentage was 56.9 versus 33.3%. Coming to the interim OS, in the intention to treat arm, at 3 years, it was 65.6% versus 58.1%. And in the PDL1 more than equal to 1, it was 71.3% versus 56.6%. Same with the recurrence-free survival in the non-urothelial tract recurrences also. There was a significant difference, that is 25.9 months versus 13.7. So almost in all these subgroups, there was a doubling of the data that can be seen with the addition of nivolumab in the adjuvant setting. So coming to the distant metastasis-free survival also, in the nivolumab arm, it was 47.1 months versus 28.7 months. And in the PDL1 more than 1, it was not reached versus 20.7 months. When come to the PFS2, that is the to start the subsequent therapy also. In the nivolumab, it was 61.2 months versus 47.1. And in the PDL1 positive group, it was not reached versus 39.4 months. So coming to the conclusion, Checkmate 274 led to the approval of adjuvant treatment with nivolumab for 1 year for patients with high-risk muscle-invasive urothelial cancer following the radical resection. An extended 3-year follow-up shows consistent long-term benefit in the DFS in intention to treat and PDL1 more than 1% subgroups. And the interim OS also showed benefit of the nivolumab in these settings. So there is a benefit of adjuvant nivolumab in patients who have a PDL1 positive expression. So thank you so much.
Thank you, Dr. Kanika. Vishal, can you proceed for the next speaker?
Yes, for the next talk, I would like to invite Dr. Priyanshu Chaudhary for the topic Avian's real-world study of amenable first line maintenance treatment for advanced urothelial cancer.
Just a second, I'll share my screen. So my slide is visible?
Yes, sir.
Yes,
So, so I'll be presenting, this topic, that is evolution in advanced urothelial carcinoma treatment to achieve quality survival benefit in patients, how we can maximize the overall survival with, a lot of newer therapies coming in picture. It's a sponsored session by Merck. So I'll be discussing first the Javelin Bladder 100, that evaluated avelumab first line maintenance plus best supportive care versus best supportive care alone in first line advanced metastatic, in locally advanced or metastatic urothelial cancer. So unresectable localized advanced or metastatic urothelial cancer who achieved a complete or partial response or a stable disease with standard first line chemotherapy, which was either gemcitabine plus cisplatin or gemcitabine plus carboplatin, given for 4 to 6 cycles. Then there was a treatment-free interval of around 4 to 6 weeks, along with radiological assessment for response. And then the patients were randomized 1:1 into avelumab at 10 milligram per kg every 2 weekly, plus best supportive care versus best supportive care alone. Avelumab was given until progression of disease, unacceptable toxicity, or withdrawal. The primary endpoint was overall survival, and primary analysis population were all randomized and PD-L1 positive population. The secondary endpoints were PFS, overall response, time to response, response duration, disease control, safety and tolerability, and patient-related outcomes. Then we had stratification by best response to first-line chemotherapy, that is CR or PR versus stable disease, as well as metastatic site, visceral versus non-visceral. So if we look at the primary endpoint, which was overall survival, the exploratory post-hoc analysis of overall survival from the start of first-line platinum-based chemotherapy in select patient treated with avelumab first-line maintenance following no progression of disease on first-line platinum-based chemotherapy. So if we look at the median overall survival, it was approximately 30 months versus 20.5 months with chemotherapy plus best supportive care alone. And if we look at the long-term outcomes with avelumab plus best supportive care versus best supportive care alone are similarly reflected in the real-world practice also. So the trial which showed results is also reflected in this real-world data. So the Javelin bladder regimen can be tailored according to the practical considerations and individual patient needs. So the overall survival benefit with first-line maintenance was observed regardless of the prior platinum-based chemotherapy, whether you are using gemcitabine or cisplatin or gemcitabine plus carboplatin. Duration of response, response to the chemotherapy. So if we look at other treatment-free interval length, if we look at here the first-line platinum-based chemotherapy, whether it's GemCis or GemCarb, the responses are pretty good in both. And then again, if we look at the duration of platinum-based chemotherapy, whether it was given for less than 15 weeks, that is approved 4 cycles, or more than 20 weeks, and they have also divided it into various quartiles, like less than 15 weeks, 15 to 18, 18 to 20, and more than 20 weeks. So every subgroup is actually benefiting. Similarly, response to platinum-based chemotherapy, whether it was a CR, PR, or a stable disease, all subgroups are benefiting. Again, treatment-free interval length 4 to 10 weeks, whether it is less 4 to 6 weeks, 6 to 8 weeks, or 8 to 10, almost all subgroups are benefiting. Now the long-term conditional survival and adverse event probability. So patient who had 1 year or more of avelumab treatment, so they are doing pretty well. If you look at the 2-year overall survival beyond the 1 year, survival probability beyond the 1 year, that is around 80%. Similarly, we look at the patients who have received progressed at 2 years of avelumab treatment. The graph looks pretty flat here, and overall survival in this patient seems to be pretty longer compared to those who have not responded. So mainly patients who are responding, they continue to respond similar to other immunotherapies. So is the efficacy markedly different with the newer regimen, that is, enfortumab vedotin plus pembrolizumab, the EV302 trial, which is now, the upcoming data, and the treatment here is, the trial was EV302 with enfortumab vedotin plus pembrolizumab versus chemotherapy. The median overall survival with EV plus pembro was 33.8 months versus 15.9 with the chemotherapy. A 2-year survival 60% versus 35.4. And if we look at now various trials which have used immunotherapies in urothelial cancers. So this was a IPD meta-analysis of these phase 3 clinical trials comparing immune checkpoint inhibitor based treatments. So we know Javelin bladder is with avelumab, Checkmate 901 is with nivolumab. It has shown an overall survival median OS around 21 months. Then we have the EV302 and enfortumab vedotin plus pembro. IM Vigor 13 was atezolizumab versus chemotherapy, did not show any overall survival benefit. Again, Keynote 361 addition of pembro to chemo did not show any overall survival benefit. So in the OS analysis, no trials showed a statistically significant advantage against avelumab when the analysis was started after the first chemotherapy phase. So if we look at this Kaplan-Meier curves of various trials, so the 3 trials which have shown overall survival benefit with respect to chemotherapy, out of those, no therapy is actually superior to avelumab. So this was the EV302 trial, first line EV plus pembro versus chemotherapy. And out of the chemotherapy arm, around 1/3 of the patient received first-line avelumab maintenance following a response to platinum-based chemotherapy. So what happened to those patients, whether they did, better, inferior, or equal to EV plus pembro? This has not been, the data for this subset has not been released yet. Now coming to the efficacy and quality of life, if we look at the data, the toxicity of first-line metastatic urothelial carcinoma treatments, if we look at the avelumab grade 3-4 treatment-related adverse events were 19.5%, while they were almost 56% in the EV302 trial. Treatment withdrawals were 11.6% with avelumab maintenance versus 35%, and dose reduction was there in 40% of patients in the EV302 trial. So almost 3 times more toxicity and treatment withdrawals with EV302 regimen, that is enfortumab plus pembrolizumab. Skin toxicity with enfortumab is, skin toxicity and neuropathy. Then the skin toxicity, around 40% of the patient had residual skin lesions, and another 40% had, continuous residual lesion with more than grade 2 skin reactions. And only 11% of the patient had resolution of neuropathy, while the rest had residual neuropathy. So these 2 side effects, when seen in elderly patients, they can be pretty troublesome. Now coming to the patient eligibility for EV302 trial, these are the EVITA proposed EV ineligibility criteria. So patients meeting any at least 2 of these criteria, 2 out of any 5 criteria, they are usually seemed unsuitable for EV plus pembro treatment. So these criteria are PS more than or equal to 2, HbA1c more than or equal to 8%, or 2 consecutive blood baseline glucose level of more than 150 milligram per deciliter at least 1 week apart, a creatinine clearance or a GFR less than or equal to 45 ml per minute, any corneal or retinal abnormality, or grade 2 or more sensory or motor neuropathy. So coming to the eligibility for our patients with who are receiving the Javelin regimen. For these patients not progressing on platinum-based chemotherapy, that they are almost 90% of the patients, they are usually eligible for first-line avelumab maintenance. While for the EV302 regimen, almost 80% of the patient would be eligible for EV plus pembrolizumab. Now, coming to the real life outcomes compared to the clinical trial data. So, the real world analysis for avelumab first line patients, we have more than 2,500 patients from US, Europe, and Asia Pacific. So the survival outcomes for avelumab first line maintenance are consistent with real world studies. We have the studies from US, Flateron 2 and Patriot data, and we have evidence from France and Malva and Reddy from Italy. So they have shown almost equal or even better median progression free survival when compared to the Javelin trial. And then again, the 12-month overall survival rate has been almost close to that, around 70% with the real world studies. So this is the data by Dr. Vineet Talwar. That is the Indian real world analysis on avelumab maintenance. The median PFS was again 5 months, which is similar to the trial. And in patient who received avelumab for 6 months or more, the median PFS was 11 months. The median OS was not reached, and 12-month OS rates were 82%. So they are mirroring what we have seen in the trials. Now coming to the EV plus Pembro real world data, we see the Unite data, which is there. It has shown that overall response rates, 12-month PFS as well as 12-month OS in the real world analysis is significantly lower than what was seen in the EV302 trial. The ORR is 54% versus 67% in the trial, 12-month PFS 30% versus 50% in the trial. Again, 12-month OS 67 versus 78.2% in the trial. Now coming how to place EV in the second line. So a contemporary sequence of Javelin bladder regimen followed by a second line EV achieved a median OS of 40.8 months from start of first line platinum-based chemotherapy. So if we look at the metastatic urothelial cancer who have received first line platinum-based chemotherapy and have not progressed, followed by avelumab maintenance, and then second line enfortumab vedotin. We have two real-world studies, that is Evidence from France and the EuroQ study. So both of these studies have shown similar median overall survival. Evidence has shown 40.8 months with this sequencing, and EuroQ has shown around 40.3 months with this sequencing. That is first line avelumab followed by second line EV at progression. Now, bringing the patient perspective in decision making, if we have our own opinions, but we need to have the patient perspective also. So, what drives decision making in practice for metastatic urothelial cancer? So, the oncologists usually prefer that prolongation of overall survival is their main goal in treating these patients. While for patients, the patient preferences were based on treatment experiences. So a better efficacy as well as a better quality of life with minimal side effects. That is what patients want. Now, this is a snapshot of different regimens, and which actually shows what these two trials have shown and how are they placed against each other. We would never have a head-to-head trial, but we can compare the pros and cons of all of these two regimens. So we look at the Javelin bladder trial, first line eligible population 90%, usually 9 out of 10 patients, while in the EV302 it is around 80%. The comparator arm, around 74% received standard of care, while only 30% patient received avelumab maintenance in the EV302 trial. The median overall survival was approximately 30 months. With EV, it was 33.8 months. But with second line EV, with the Javelin protocol, it has shown to be close to 41 months. Median PFS, 9.5 months versus 12.5 months. And in real world analysis, it is again even more with Javelin, 13.6 months. Sequencing after first line avelumab maintenance, you can always give ADC, that is the EV monotherapy, achieving an OS of 40.8 months, while for EV302 we have practically no data what to use after progression on this therapy. Grade 3 or more treatment-related adverse events, 20% with Javelin and 56% with EV302. Discontinuation rate 11.6% versus 35% with EV302. Convenience of administration bi-weekly, lesser adverse event management, while it is weekly for the EV302 to start with. Again, now coming to median overall survival in trials in different first-line treatment options. So we'll start from the bottom, that is the Checkmate 901, cisplatin eligible only, Nivo plus Gemcis. Again, followed by Nivo maintenance, survival is 21.7 months. Javelin, platinum-based chemotherapy, then after maintenance, without EV, would say around almost 30 months. This was in all patients, cisplatin-treated patients. After platinum-based chemotherapy and avelumab maintenance, the survival is slightly longer, around 31 months. For EV302, EV plus Pembro, median survival is 33.8 months. While in the Evidence real-world study with the Javelin bladder protocol, first-line platinum-based chemotherapy followed by avelumab maintenance, followed by enfortumab vedotin on progression, the survival is reaching the highest, that is 40.8 months. So I think this is a reasonable strategy for patients of using first-line avelumab maintenance in patients who have not progressed on first-line chemotherapy, and then switching over to EV on progression and achieving the maximum median overall survival. So thank you. This is all I have to present here.
Thank you, sir. So for the next talk, I would like to invite Dr. Jatin Salim. So he's Director in Medical Oncology from IV Hospital. So the stage is all yours, sir.
Good evening, sir.
Good evening to the organizer. Ivy and Livasa are one, so me and Priyanshu are in the same hospital. Thank you, Priyanshu, for inviting me to share a data of Niagara trial. Well, there is a lot of enthusiasm about the Niagara trial, and yes, rightly so, because there has been some unprecedented results with the addition of durvalumab to, sorry. Yeah. Is my screen visible?
Yes, sir, your screen is visible. Just make it full screen.
Trying to do. I'm not able to make it full screen. I don't know what is the reason. Just a minute.
Sir, you want us to share from our side?
Yeah, if it is possible, because I'm not able
Okay.
to make it full
Okay, no issues. I will share from
screen.
my.
I'll stop share.
Slides are visible, sir?
Yeah, thank you. So this was an abstract in ASCO GU 25. Additional efficacy and safety outcomes and exploratory analysis of the impact of PCR on long-term outcomes from Niagara. So what was Niagara all about? Next slide, please. So it was demonstrated in Niagara that the addition of perioperative durvalumab to neoadjuvant chemotherapy, statistically significant improvement was observed in both EFS, in which there was a hazard ratio of around 0.68, and OS hazard ratio of around 0.75. Plus, there was a 10% improvement in PATH-CR. And additionally, there was no delay to surgery and no impact on patient's ability to undergo complete surgery. So here we have additional efficacy and safety results from Niagara. Next slide. So this was the trial design in which there were 4 cycles of in the cisplatin eligible. So this trial was specifically done in the cisplatin eligible patients only, and who were clinically T2 to T4A and 0 or N1, and urothelial cancers, and the important thing was urothelial cancer with divergent differentiation or histological types. This is very important because not uncommonly we do get urothelial cancer with squamous differentiation or with some other differentiation, and they do behave slightly worse as compared to the classical urothelial CAs. The patient should have a creatinine clearance of more than equal to 40 ml per minute. So durvalumab arm had 4 cycles of gem plus cis along with durvalumab 1500 mg, and comparator arm was the gem plus cis arm, and radical cystectomy was performed, and durvalumab additional 8 cycles adjuvant was given, while no adjuvant treatment was given in the chemotherapy arm. The primary endpoints were EFS, PCR, and the key secondary endpoint was OS. The secondary endpoints also included metastasis-free survival, disease-specific survival, immune-mediated adverse events, and there was an exploratory post-hoc analysis of EFS by PCR and OS by PCR. Next slide. So this was in the intent to treat population, metastasis-free survival, and it was shown that the risk of distant metastasis or death was reduced by 33%. The median metastasis-free survival in the Durva arm was not reached in either arm, rather. So the hazard ratio was around 0.67. Next slide. Next slide. And perioperative Durva also reduced the risk of death from bladder cancer by around 31%. Next slide. So the PATH-CR, as we can see in the IO arm, the PATH-CR rates were around 37.3%. with the odds ratio of around 1.6. Well, in the comparator arm, it was 27.5%. So that is also quite impressive. But there was a 10% improvement in PATH-CR rate. Next slide. So these were the demographics and the disease characteristics. And we can see the arms were matched pretty well in both patients with PATH-CR and patients without PATH-CR. There were equal number of patients, and the only difference in patients without PATH-CR was the PDL1 expression less than 25%, TC oblique IC, was slightly more as compared to the ones with the PATH-CR. I mean, there were more of good amount of PDL1 expression in patients with PATCR as expected. And there are equal amount of urothelial cancer, but divergent histology. And mostly you see in both PATCR and non-PATCR group, they were mainly node negative patients, clinically node negative patients. So please mark that very importantly that the major chunk of population was node negative. Next slide. Next slide. So EFS in both PCR and non-PCR group improved. In PATCR group, it was around 0.58. That is PATCR with both the comparator and the Durva. It was still the EFS hazard ratio was 0.58. And in the non-PCR, it was 0.77. Next slide. So Niagara overall survival also in PATCR, yes, the hazard ratio was 0.72, while in non-PATCR it was 0.84. Overall, in the intent to treat population, the hazard ratio was around 0.75. Next slide. So serious adverse events were not much of a difference. The only thing was that yes, obviously in Durva arm there would be you know and rest most of the adverse events were evenly matched between both the arms. Next slide. So again, mostly it was immune-mediated adverse event in the overall study period. They were grade 1 and 2. Very few grade 3 or 4 adverse events were there. Next slide. So the conclusions are the Niagara demonstrated statistically significant, clinically meaningful improvement in EFS with the hazard ratio of 0.68 and OS with a hazard ratio of 0.75 with the 10% improvement in PATCR. In the durvalumab arm, the risk of MFS event was reduced by 33% and the risk of disease-specific survival event was reduced by 31%. So perioperative Durva plus NAC improved EFS and OS in both PATCR as well as non-PATCR groups. And immune-mediated adverse event are mostly low-grade, consistent with the known profile of Durva. So the additional Niagara data further supports perioperative Durva with NAC as a potential new treatment for patients with cisplatin eligible metastatic invasive, muscle invasive breast, bladder cancer. So thank you.
Thank you, sir. Sir, would you be inclined to use it in node negative?
Node negative, yes, I would use it. Rather, I would have really wanted something in patients who would be a node positive, and even if they were subcentimetric nodes on scanning. But yes, I mean, in bladder, anything, even if it adds to few marginal improvements, I would definitely like to use it if the patient is one cisplatin eligible, and second, if the patient can afford durvalumab. Both in node negative and node positive, I will use it if given a chance. But I'm still a bit skeptical about the data about node positive.
And also, sir, I think a large number of patients
Yeah.
won't be going for surgery and maybe go for some CTRT stuff.
Yeah, so in meta-analysis, it has already been found that neoadjuvant treatment has a role only in patients who undergo surgery. Otherwise, there is no role of neoadjuvant chemotherapy, at least. I don't know about the IO, because neoadjuvant IO before CTRT has not been studied, or maybe there must be trial going on for that. Interestingly, there are trials in which if you say bladder preserving therapy, then in that case, people are now doing that. They are giving chemo plus IO, and if the patients achieve clinical CR, just like total neoadjuvant therapy of rectal cancer, they are observing or giving them additional IOs. And there is an interesting phase 2 data which has been reported in ASCO last year, that if you don't want to give even radiation, if the patient doesn't want to go even surgery, then there can be a select group of patient in which you can just give chemo immuno and some immuno maintenance. And if they remain in clinical CR, you can easily observe them. So there are a lot of studies coming up like this.
At least, sir, now people are talking about PAT-CR and bladder.
Yeah, it is, yeah, just like breast cancer. I mean, they are thinking about PAT-CR, and I'm really heartened to see never concentrated on PAT-CR so much. It's in this particular trial, I was very amazed to see that the chemo alone itself has around 25 to 30% of PAT-CR. So that was very impressive.
Yes, we even I never knew that data, sir.
Yeah.
I think thank you, sir, and
Thank you.
we can move forward.
Okay. So I hope my screen is visible and I'm audible.
Yes, sir.
Okay. So I am here to present another abstract. So I must congratulate Priyanshu that the abstract selection was wonderful, and whatever abstracts have been presented till now, so they are all practice changing as abstract. So this is another abstract by the name Wolverine. So it is a meta-analysis in oligometastatic prostate cancer, where standard of care therapy was being compared with the SOC along with local therapy to the metastasis. One second. Okay. So to introduce the topic, there are more prospective randomized data which exist for management of oligometastatic prostate cancer. But for the management of prostate cancer, where a local therapy is considered for oligometastatic site, so there are few phase 2 trials, so there are no large phase 3 trials. And so this thing is still not clear. And there has been hypothesis regarding the patient groups who do or do not benefit from metastasis directed therapy, but the subgroup analysis are limited. So this meta-analysis, so it was an XMET collaboration, and it included all randomized data investigating oligometastatic solid tumors. So they had they had identified all published trial randomizing oligometastatic prostate cancer patients to metastasis directed therapy and SOC versus SOC alone. Here, in few of the trials which they have included, the definition of oligometastasis was taken as less than equal to 3 metastases, and some trials they have taken less than 5 metastases. So technically, as we are taking it in all other cancers, oligometastasis. So it is 3 to 5 site of metastasis which has been taken as oligometastatic in this meta-analysis also. So the endpoints which were taken here were progression-free survival, radiographic PFS, CRFS, which is castration resistance-free survival, and this was particularly in those patients who were to begin with castration-sensitive prostate cancer, and this was defined as achievable of CRPC or death. So, and overall survival. So these were the four endpoints which were selected in this, and they had taken the individual patient data. So it was not a trial-based data. So it was a individual patient data was taken from all these pooled phase 2 trials. So there were two parallel analyses which were conducted. So one was using the common and random effects model. So these are some statistical analysis where there are multiple studies which have been taken, and one in the common or the fixed effect model, it says that probably the difference it is due to the exact treatment, and the random effect model, it basically says that all the studies, if there is a difference, so it is by chance. So the Cox regression analysis was also performed. So these were the statistical analysis which was performed. So they had included these majorly 6 studies. So one is the COMET study, which had contributed to 16 patients. Then extend, there were 2 studies. One was the intermittent and one was continuous androgen deprivation therapy. So here 87 and 96 patients were taken, and the largest data which had come was from the Florence Artos trial, and other one were the Oriole and Storm trial. So these were the patient characteristics where the second generation androgen receptor pathway inhibitor were included in 60% in SOC arm and 50% in the experimental arm. Looking at CRPC versus CSPC, CRPC were 46% in SOC versus 38% in experimental arm. Looking at those patients who had prior treatment, 17% patients they were de novo, and 83% of the patients they had taken prior treatment. And these patients, in total 472 oligometastatic patients, they were either given standard of care, which could be whatever, could be anything, and this was compared with SOC along with metastasis directed therapy. PFS analysis, on the left side, it is a trial level analysis on the basis of random effect model. What we can see over here is that the hazard ratio was 0.444 in both common effect model and random effects model. So which was in favor of metastasis directed therapy. Looking at the Cox regression analysis, again, the hazard ratio was 0.45. If we look at the median PFS, 14.9 months in SOC versus 32 months with the metastasis directed therapy addition. So looking at the subgroups, we can see that the benefit of MDT was seen among all the subgroups, be it CRPC versus CSPC, or the type of imaging, or whether the patient was having nodal positivity or the metastatic disease, or the patient had received or the number of metastases. So all the subgroups, they had advantage in favor of PFS, advantage in favor of MDT group. Coming to radiographic PFS, which was another endpoint, again trial level analysis showed that the hazard ratio was 0.6, and Cox regression analysis also showed 0.59. And the median radiographic PFS was 21 months in the SOC arm and 35 months with the MDT plus SOC. So this was another endpoint, which was the freedom from castration resistance. So we can see the common effect model on the left side. So hazard ratio 0.579. And if we look at the Cox regression analysis, 0.58. So almost close to each other. And the median was 72 months versus 63 months. Overall survival was also higher with the MDT treatment, and the hazard ratio was 0.625. And with the Cox regression analysis, it was 0.64. So to summarize, the pooled analysis of all published trial randomizing oligometastatic prostate cancer to SOC with or without metastasis directed therapy revealed improvement in progression-free survival, radiographic PFS, and the castration resistance-free survival. So MDT also improved overall survival. However, it was not statistically significant. MDT benefit was maintained across all subgroups, including patients with untreated primaries, staging imaging, castration sensitive or castration resistance disease, and treatment with or without ADT. So these are the ongoing trials which are particularly looking at the oligometastatic prostate cancer. These are Platon, Presto, Starport, Stampede 2, and StartMed. These are going to give us further insight about the management of this disease. With this, I would like to end my talk. Thank you for patient listening, and if there are any questions, I'll be happy to answer those.
Thank you, sir. I think we can move forward.
AOI Jammu. So the stage is all yours.
Okay, Surangi, please do the presentation slides.
Sure.
Good evening, sir.
Thank you, Dr. Priyanshu. So, my job is to speak on advanced RCC in second line and beyond. So there are a few new options which needs to be, discussed. So 2-3 abstracts I have to present. Can you enlarge this? Okay. So first we will be discussing Keymaker U03 substudy 03B. So pembrolizumab plus targeted therapy combinations for advanced clear cell RCC. Next slide. Next slide. Yeah. So this sub-study, the CLE eligibility was obviously clear cell RCC, histologically proven, and disease progression post first line, either sequentially or combination with PDL1 inhibitor or VEGF TKI, or the reverse sequence was also allowed. And measurable disease as per RECIST criteria and KPS 70 or more. And these were initially randomized into arm B4 and B5, and then further 4 randomizations were done. And it was an efficacy phase study. And in arm B1, B2, B3, so pembrolizumab along with a few investigational drugs with CTLA4 inhibitors, QMAP, and ILT4 inhibitors, they were tried. And in arm B4, pembrolizumab was studied with belzutifan. And this drug is a HIF alpha 2 alpha inhibitor. And in arm B5, it was lenvatinib plus belzutifan, and the next was pembrolizumab plus lenvatinib. So there were key stratification factors as per the IMDC risk group: low, intermediate, and poor risk. And prior, whether or not prior CTLA4 inhibitors were allowed, yes or no. So, and the primary endpoint was overall response rate. So in all these arms, overall response rate was the primary endpoint, and secondary endpoints were disease control rate, and the PFS by BICR and OS. Next slide. So baseline characteristics, if you see, they were equally matched in all the arms. Especially we can see in IMDC, risk group, intermediate and poor risk. So intermediate were around 2/3 of in each arm, and poor risk were around 10%. Sarcomatite features were less than 10%, and prior CTLA4 inhibitor use was allowed in around 1/3 of each arm in each arm. And if you see number of prior lines of therapy, so most of the patient, almost 90% of the patients were second line and beyond. Next slide. So this is also the first efficacy lead study. So here also the baseline characteristics were largely the same. So results. Next slide. Yeah. So if you see of all the regimens, the second and the third, that is Pembro plus Fave and Pembo plus ILT4 inhibitor, the overall response rate were 0%. So they were not efficacious at all. And in the Pembro plus QMAB, that is a CTLA4 inhibitor, around 30% of overall response rate was seen with a grade 3 to 4 adverse event of around 25%. And median OS was not reported. Similarly, Pembro plus Lenva and Pembro plus belzutifan. Now, these combinations, if you see, they have also quite good overall response rate with good PFS and good median overall survival of 27 months. So this is kind of in second line and beyond 27 months of median OS is quite substantial. But the more important to see is the grade 3 or to 4 adverse events. It's almost 42% in the Pembro plus Belam. And in the Lenva plus belzutifan, and the adverse event rates were very high, of almost 60%. Next slide. So the key takeaway message is that the targeted therapy arms, in the targeted therapy arms, Lenva and belzutifan showed best efficacy, but with adverse events requiring dose modifications. Pembro-Bel or the Pembro-Len benefits are likely driven by the targeted agent and not by the Pembro. And the IO arms, Pembro plus CTLA4 showed modest overall response rates with favorable adverse events. But PDL1 and LAG3 or ILT4 inhibitors, they had no responses. Standard of care still remains targeted therapies with limited role of re-challenge of anti-PD-1 after progression on IO. Next slide. So R20, this was a phase 1 dose escalation study and dose study of casdatifan. So casdatifan is again a HIF-2 alpha inhibitor. And here in this study, different doses of casdatifan. Next slide. So of all the doses, if you see 50 milligram BD, 50 OD versus 100 OD. So 100 OD was the safest drug with the drug dose with the very, very little less than 10% grade 3 and beyond toxicity, adverse events. Next slide. So now this peak one, this is a phase 3 currently under trial. And herein they are evaluating casdatifan with cabozantinib in advanced metastatic clear cell RCC following PD-1 therapy. So second line and beyond, if the patient is naive to cabozantinib and naive to HIF-2 alpha inhibitor, so they are being randomized into 100 milligrams OD dose of casdatifan plus 60 milligram of cabo versus cabo alone, and quite a substantial 700 patient study. And the primary endpoint of this trial is PFS. And these results are anticipated in mid of 2025. So this is one drug combination. We are, sincerely looking into it, and the results should be out soon. Next slide. So that's it from my end, and I take it back to Dr. Priyanshu.
Thank you, sir, for finishing on time. I think if we have no questions, we can move forward.
Okay.
So for the next talk, I would like to invite Dr. Ulfat Ara, Assistant Professor, Department of Medical Oncology from Kashmir Institute of Medical Science, Sora, Srinagar. The stage is all yours, ma'am.
Kindly share the presentation from your side.
Sure.
Very good evening, ma'am.
Very good evening.
Are the slides visible, ma'am?
Yes, they are visible. Okay, today we are going to discuss the breakwater trial which has been done in colorectal cancer. As we all are aware, colorectal cancer is among the third common malignancy in the world and the second leading cause of cancer in the world. Next slide, please. Next slide. Basically, we are going to discuss the BRAF mutated subgroup of the colorectal cancer, which has BRAF V600E mutation, which occurs in 8 to 12% of the metastatic colorectal cancer. This group of patients, as we know, have the double mortality as compared to the other subgroups of the metastatic colorectal cancer, and this is an unmet need. As we have got a background idea from the Beacon study, which has actually incorporated encoforenib, a BRAF inhibitor, in the subsequent line of treatment for this subset of patients, Breakwater trial is an ongoing phase 3 study which is evaluating the efficacy of the combination of BRAF targeted treatment with cetuximab and chemo upfront in metastatic colorectal cancer patients. Next slide, please. The objective of the study was to evaluate the efficacy of the combination of encoforenib, cetuximab with chemo versus standard of care. The standard of care of these patients was actually the backbone of chemo with or without BEV. And the backbone chemo was Capox, FOLFIRI, and it was also this modified FOLFOX6. The primary endpoints were basically progression-free survival and the objective response rate. The first term interim analysis also concentrated on overall survival, duration of response, time to response, and safety in this group of subset of patients versus the standard of care. Next slide, please. This study design was that actually the patients who had upfront metastatic colorectal cancer with BRAF mutation positive, with performance status ECOG 0 and 1 was included. And there was basically this trial was conducted in 28 countries, and the comparison was US, Canada versus Europe and rest of the world. And the patients who were having brain mets, they were excluded. Patients which were having MSI high, they were excluded. And patients who had neoadjuvant treatment duration less than 6 months and then they have got the metastatic disease, they were also excluded from this study. And actually the patients were included were more than 16 years or more than 18 years as per the country's criteria. And then they were basically randomized first initially in the trial to 3 arms, that is the combination of encorafenib with cetuximab, and then encorafenib cetuximab with chemo, and the standard of care. Later on, this subgroup of encorafenib cetuximab was dropped, and 1:1 randomization was done to the combination of the encorafenib cetuximab with chemo versus standard of care. Next slide, please. This was the trial design was well matched in both the groups, that is the encorafenib cetuximab modified FOLFOX6 versus the standard of care. As far as the site of disease, colon, rectum, and cecum was concerned, the right-sided patients were more the right-sided colon patients. These were both in the both arms 62.3 versus 59.7, and most of the patients were metastatic, as I have already said, upfront metastatic, not received any prior treatment, and not also received any BRAF targeted or EGFR treatment. And the response rates, if you compare, the complete response rates in this subset was 49% versus standard of care, which was 43%, and the partial response was 5.9% versus 5.3%. Number of organs involved was also well matched, and we can see the MSI status was also well matched in these patients. We said, as already I have mentioned, the MSI high patients were excluded from this trial. Next slide, please. The efficacy result analysis was done and was found that the combination of this targeted treatment BRAF with cetuximab with modified FOLFOX6 showed 60.9% response rates, which was appreciably high as compared to standard of care, that is 40%. And the median duration of response was also good, 13.9 months in this arm versus 11.1 months standard of care. However, the interim analysis was done for overall survival, which did not show much significant difference, although we had seen that there was some, separation of the overall survival curve initially. And this was done because actually the overall survival analysis was only done at 10.8 months in the trial arm versus 9.8 months in the standard of care arm. Next slide, please. Next slide. We can see the efficacy results. Again, this is showing that the response rate 60.9% in the trial arm versus the standard of care, which was 40%. So there was a difference in response rate of approximately 20%, which is an achievement. And then we can compare that the all responses, that is where the CR rates, which are 2.7% in the trial versus the standard of care, which was only 1.8%. Partial responses were also high, 58% in the targeted treatment arm versus the standard of care. And stable disease also we can see was well matched. And progression was only 2.7% in the trial arm versus 8.2%. Then the duration time to response was 7.1 weeks in the trial arm versus 7.3 weeks. And we know that the duration of response, then it was compared in the 6 months and 12 months. Again, we can see that in the 6 months, more than 6 months, the duration of response was achieved in the trial arm at 68.7% versus 34%. And again, the patients who had maintained the response for more than 12 months was 22.4% in the trial arm as compared to the standard of care, that is 11.4 months, which is also an achievement. Next slide, please. Next slide. Now, in this forest plot, we can very well, actually now see that all subset of patients have benefited from this combination, whether it was as regards age, gender, or performance status, but only 0 and 1 was included in the trial because the drug toxicity is high with this combination arm. And actually the number of organ involvement is also there. And especially it was found that the patients who had presented with liver mets also benefited in this trial arm. And then whether it, depending upon the sidedness of the tumor, whether right or left, both arms had actually a benefit. Next slide, please. Now, this is actually the overall survival comparison. We have actually seen that the 6-month OS was also improved. That is 92.3% versus 87%, and 12-month OS 79.5% versus 66%. But if you compare the trial arm with the standard of care, there is an early separation of the overall survival curves. And the overall survival ranged from 19.8 months to not estimated versus the standard of care, which was 14.6 months. So the median OS was 19.8 months to not estimated versus 14.6 months, although this was an interim overall survival analysis and the hazard ratio was only 0.47, did not reach statistical significance, but in future maybe we get an OS advantage as well with the continuation of this trial. And the events as far as they were concerned were 40, that's 16.9%, and in the standard of care it was 29.6. Next slide please. So the safety profile, the treatment emergent adverse events were similar between the groups. Most common adverse events, as we know, is nausea, anemia, diarrhea, neutropenia, vomiting, and grade 3-4 adverse events were higher in the trial arm, that is encofarinib, cetuximab with combination of modified FOLFOX6, 74% versus 61%. Next slide, please. So we know that the grade 3-4 adverse events, if you see, compare with the trial arm with the standard of care, again it is slightly higher, it is 74% versus 61%, but the grade 5 events almost comparable, and the serious adverse events were 37% in the trial arm, higher than the standard of care, that's 34.6. And we know that the side effect profile very well matched with the drugs as known drug side effect. Like encofarinib, we know that discontinuation is in almost 11.7%, and cetuximab as the cause of discontinuation 13%. Dose reduction was also as per the expected drug profile. Next slide, please. So if we conclude this trial, we know that the BRAF mutated patients actually have signaling through the MAP kinase pathway, and it reactivates. If we target this mutation, we are reactivating the EGFR pathway, and therefore this is an important subset of patients with overall higher mortality. And since encofarinib is a ATP small molecule competitive inhibitor for this BRAF mutated patients with a prolonged duration of efficacy, pharmacodynamic efficacy is prolonged. So we can say that this is a standard of care for these patients. Although we will have to see the results from this trial, especially in the MSI high patients where there is a CMARC, which is a trial ongoing, where there is a combination of pembro with this encofarinib with modified FOLFOX6. They are seeing the results in that trial, and a second cohort where they are actually comparing FOLFIRI in combination with encofarinib with cetuximab versus FOLFIRI as a standard of care. We'll get those results also. And we can get from this trial, there is a manageable toxicity profile. This is a new armamentarium of treatment, especially in this subgroup of patients, where upfront this BRAF and achieving good results as of now. interim overall survival analysis, time to response plus duration of response, and remarkable results as far as overall response is concerned. So we know that this drug has been approved by the FDA on 20th December 2024 for the subset of patients. Thank you. Thank you for a very patient hearing.
Thank you, ma'am. Your take on probably the cost effectiveness of this therapy?
Yes, actually, cost is a concern as far as our setup is concerned. Definitely, the cost is, and then safety is. Then the subgroup of patients we will have to, because toxicity definitely is higher as compared to the standard of care. We have to consider these things in our clinical practice, because then we know that this subset of patients, they don't fare well also.
Yes, definitely.
Definitely.
So I think, ma'am, you rightly said cost and the toxicity. So both of these are important factor in deciding when we start a first line therapy, where cure is not the our ideal thing to ponder about. But I think with a subset of patient who might be able to afford and who are young and probably a little bit fitter, because these patients are actually not even fit for other EGFR inhibitors. So I think for those subset we might have an option, at least theoretically. It will take some years to get it into practice, I guess. Even I have not used yet this combination.
Yes, we have also not used, but it's ongoing, and we may see the results also in future, because interim OS analysis is only available.
Yes,
so if we come up with the better OS later on, and some other things like MSI high subgroup of patients, and as I said, there are certain trials going on in that subset with this combination with Pembro also, and we'll may get results in future. Yes, exactly. This is a we can say, and for us it is still yeah, it's still investigation.
It's fine, Dr. Deepak here. So it's okay that we know, but there are still certain patients which are KRAS mutant and who are BRAF mutation will be there on that patient, and we know they are progressed on all the lines, and they're still PS1 or PS2, PS0 patient with us. There are certain subsets where we can offer this subset, because I have 2 or 3 patients who have same profile, who are fit for this regime, and some more they're not able to get connected to that encorafenic from outside the way around.
But I think we had the second line approval earlier only, but this is the first line which we are talking about.
This is first line upfront, and they have excluded RAS mutated patients because of the risk of secondary malignancies, especially the dermatological malignancies. That is why the RAS subset has been excluded from this trial. So still we have.
So because we are not using a MET inhibitor, so I think.
In this combination we are excluding the MET inhibitor. That is also the reason that the cutaneous malignancy rates go higher.
Yes, ma'am.
Yeah.
Thank you, ma'am. Thank you for such an important discussion here.
Thank you. Thank you for inviting.
And pleasure is mine. Dr. Deepak, yours is the next talk. You can.
Please. Okay.
You can take it from here.
I will do it, my friend. I think it's fine. My slides are visible.
Yes, sir, you can move.
Yeah. Okay. So first of all, congrats, Dr. Priyanshu, and then thanks for inviting me to our organizers, and especially Dr. Priyanshu. And I think the topic is from the alma mater from Dr. Priyanshu, and I think I also came to the trial later on, but the trial has been designed way back in 2018 by AIMS, and I have nothing to disclose. It's all the slides and all the things provided by the organizers. So
just to add on that, sir, we have actually patients of this trial. So
yes, definitely. That I know this topic is from your heart, and that's why you have given this topic to me. Thanks a lot. Okay, so we know that in gallbladder cancers, whatever we can do in non-metastatic, we need nothing to offer. Only the adjuvant chemotherapy is there. But we want to improve the survival, and we want to see that anything can be done to the patients. So the trial has been designed by our AIMS Delhi. The name of SLA trial.
So gallbladder cancer has poor prognosis post-surgery. Role of adjuvant therapy remains unclear. We know we have only BILCAP study where we can use capstamin only, and all other preferred regimes, whatever physician can choose. There is no prior prospective trial comparing the chemotherapy with chemo plus CR, chemo radiation. So the endpoint what they have chosen up is the relapse-free survival in resected gallbladder cancer after giving chemotherapy, and once after they are given chemo with addition of radiation. So it is a phase 3 open label randomized controlled trial. Population are including both, which have R0 and R1 sections. And I will tell you that all the patients which are included here, all have get R0 section. They are randomized two arms, arm 1 and arm 2. One receive chemotherapy and whatever physician can choice of their direction with Gemox or Gemsys. And arm 2, they are using chemotherapy, the same regime with chemo radiation. And after that, they have chosen total 6 cycles, either with a sandwich regime or whatever they can use. But trial form, they are using 3 cycles, then radiation, then 2 more cycles with chemotherapy. So these are 2 regimes what they have chosen up, and the standard radiation protocol what they have decided, the 25 fractions with 45 Gary, and then they are using with concurrent capstamin, the lower dose of 825 mg per meter square BD with radiotherapy. So they have planned 100 patients, but after that they have actually they've got 94 only, and just you want to see the timeline is 18 to 2021. There the pandemic of COVID was there, and they because of that they will go slow accrual, because otherwise if it's not the case that things will get in touching 6 months or 1 year only. Such a huge burden of GB malignancies there in North India. So median age, what was they have found, it is 55. The youngest is 27 and the elder is 73-year-old. All are getting a good PS, touching 88% population. Equal gender distribution, and out of them 32 are female out of 47, and all patients have RO sections undergoing of that. So just I want to highlight one thing here. Just all the 6, they have included 6 cycles only, but in arm 1, just see 85% patients have completed the treatment protocol, but in arm 2 they are just taken 62% only. So touching 40% patients are not able to complete their strategy regimes, and that might play a role in deciding the what results we have seen. So similar dose reduction delays will be there in both the things, but some sort of things that because RTS and added up, maybe that part have played, and more of the patient not able to complete the full treatment after giving radiation. So they have decided to give in 3 or 4 cycles only. They're not able to complete 6 cycles. That we all know with capstamin and Gemsys, the diarrhea and neuropathy will be there. So then come to outcomes is a relapse-free survival. Till now, they're not estimable in arm 1 till the time they have closed the study, but in arm 2 they have found 34 months with no significance. They have found that in overall survival similarly things will have happened, not as estimated in this thing, and 34 months in arm 2. So this way they have told the thing that nothing can be concluded from this the trial, and we know that chemotherapy is still the one word to go forward in carcinoma gallbladder. So what they have concluded that addition of chemoradiation to chemotherapy did not improve outcomes. Chemotherapy alone may be sufficient, and larger studies needed to confirm findings. But I just want to highlight, and just time will be there. Just I want to highlight one more thing. The time duration where the study have started up 2018. The similarly 1 year after that, there's a one phase 2 trial has been started by Tata Memorial Mumbai with the name of GICOR. Similarly set of patients they have chosen up, but in that they have compared the things with original capstamin only. They have included the things into 2 parts with capstamin versus capstamin RT. But point what I want to highlight here is that they have concluded the things for 3 years. They have included 90 patients, and they want to see the DFS as the endpoint. Here we are seeing the RFS. They have seen the 1 year DFS, but they have continue the study. Later on 2023 they have updated the OS benefit in JCO. What they have shown that, and they have segregated things to stage 2 and stage 3. What they have found that in stage 2 patients are getting somewhat similar benefit with radiotherapy, but in stage 3 patients they are clearly getting more benefit with chemotherapy as compared to radiotherapy. Although data is very mixing up, but what they have concluded that stage 2 anything can be given either with the addition of radiotherapy. In stage 3 they want to give with chemotherapy only. Radiation is no benefit, even it is inferior to chemotherapy in that trial. So that way I will tell that maybe in future we can make us more wiser, but at present we are good to go with chemotherapy only, or something can maybe some studies are going on, we can make it go more wiser. At present I just want to give these 2 inputs only. If something is there for me, please let me know, and Dr. Priyanshu will throw some light on this trial. And I think he must know about GEEK or what I'm telling about TMH. They have started the trial 1 year after the accelerator has started up. Yes, Dr. Priyanshu, thank you.
Thank you, sir. Thank you. I think COVID impacted the recruitment of this trial, so that was also one of the reason.
Similarly, TMH also, they have started in 2019 to 2021, 2023. So they have also impacted the things. They have included 90 patients, similar design. Only thing is that they have compared the things with the standard capstamine only. They're using only capstamine only.
Yes.
They're not
Not
use
the
gemcitabine.
Gemcis or Gemox. I
Hmm.
agree. But I think with the bell cap regimen, I'm not very much,
Mhm.
comfortable using that, because this
Disease is
disease
so
will not
deadly. We
give you
know that.
much of a time. If you give capecitabine and then it relapses, otherwise also you will be giving
Okay.
Gemcis or Gemox.
What I use in my routine practice, although if someone is fit, I will give anything. But if someone is not positive, I will give the addition of gemcitabine. If someone is not negative, then I can discuss both the things. Depending on the patient PS and age and performance status, I will give capstabine also, because legally and other way around, you have to tell the patient that what we are giving, because these days legal and other formats are also there. If you add gemcis or ask gem cap, because these all are the other preferred regimes. Still no, only capstabine is the preferred regime comes in the NCCN, and although we both are okay, and I am also treating the patients with additional gemcitabine, but I keep node positive as addition. If node negative, I still can go with capstabine also.
Perfect. Thank you, sir. Thank you.
Okay, thank you.
Thank you, sir. So for our next talk, I would like to invite Dr. Jagdeep Singh. He's medical oncology hematology from Ludhiana.
Sarin is in Amritsar now.
Hi, Praju.
Hospital, sir will tell.
No, I'm still with the same only. That anyhow, thank you, Pranshu.
Welcome.
Uh, so to the organizers, you will move the slides.
Sure, sir. I'll share it from my end.
So lots of when changes are there, the things usually doesn't get updated. Even some of the other companies, it is written as AOI Ludhiana also.
So they're missing you in Ludhiana, sir. DMC guys are really missing you.
I don't know who's missing. Somebody is missing there.
It's not even AY anymore now, I guess.
No, it's still there. Pranju,
Still there.
maybe I have heard that they're getting some 6 months more extension.
Okay.
Yeah. So anyway, thank you so much for giving me this chance to give some highlight on this Himalayan trial. So we all know this unresectable hepatocellular carcinoma. This is always a challenge for us, because initially we had only a single drug, and decade later we got another drug, that is lenvatinib. And in the same time, 2-3 years down the line, we have this combination of anti-VEGF and this IO, and then we have this combination of dual IO. So next slide, please. So we all know this liver is the 7th most common cancer and 4th most frequent cancer cause of the cancer-related death globally. And if you take into consideration for India, next slide, please. It is again one of the most challenging, because the incidence is and mortality is almost matching in patients with the hepatocellular carcinoma unresectable in our setup. So if you see in this diagram, approximately close to 45% of the patient at diagnosis have some sort of lymph node metastasis or advanced metastasis, and the prognosis of those patients is really poor. So you can see in that bar, the patient who have localized disease, the 5-year survival rate is close to 30%. But as you go down the line distance, that outcome is really dismal. So it's close to 3% in the patient who had a distant metastasis. Next slide, please. So this what I was talking, that in India, if you see the incidence and the mortality, they're very much close to each other. So the reason, because we usually we usually have the patient in a very late stages. That's why incidence as well as this mortality is almost close to each other. So in our setup, it is the 11th most common cancer and the 8th most common cancer for the cancer-related mortality. And in male, it's the second most cancer death in SCC in our setup. So male to female ratio is 4:1, and median age is from 40 to 70 years of age. And this incidence of SCC in cirrhotics in India is close to 1.6% per year. Next, please. So a lot of factors contribute to the development of this cirrhosis and fibrosis, and ultimately this form a platform for SCC. If you see a lot of etiological events, that is viral, nor-viral, or metabolic, they ultimately lead to a cascade of reactions, and there ultimately occurs a lot of immune network dysregulation leading to fibrosis, cirrhosis. And this multiple mechanism of this immune escape evasion leads, leading to the hepatocellular carcinoma. Next slide. So the risk factor, as I was already stating, viral usually hepatitis B and C. And now that toll is taken up by the other things, that is the environmental factor in which the NFLD and the alcohol are taking. And even the NFLD or NASH, that is even surpassing this alcohol. So these all causes either viral or substance abuse related to alcohol or tobacco, and with the metabolic causes, that is the NFLD, and mostly diabetes and obesity, which is another factors leading to NFLD. All these factors leads to the risk factors, which leads to the cirrhosis, and ultimately it will result in the hepatocellular carcinoma. Next, please. Next slide. So this was a study which showed that etiological fractions in patients with the SCC India, with or without a background. So this was a multicentric trial, and it has been shown the important risk factors for development of both cirrhotic and non-cirrhotic SCC in India. And it has been overtaken, that's viral hepatitis has been overtaken by the NFLD. So initially the patient, they usually have the viral etiology, and now it has been said that's the NFLD leading to hepatitis and ultimately leading to SCC is the most common cause of this hepatocellular carcinoma in our continent, in our country. Next, please. So now coming to the management of this advanced unresectable hepatocellular carcinoma. Next slide. So this is the most important BCLC staging of the liver cancer, which was initially till 2021, and it was updated in 2022 because initially we take into consideration the child bookstore, and that was more focused on, as you can say, non-preserved function of the liver, and that was also incorporating some sort of a MELD score also. But with the updated BCLC score, we have more robust information how to go with the treatment for the patient, whether they are in very early stage, that is a BCLC stage 0 or A, and B or C, depending upon the multinodularity, and whether we are able to do any sort of local therapy or patient requires a systemic therapy in the setting of any portal vein invasion, or if a patient is having terminal disease, we offer a best supportive treatment. So based on this, we have a different outcomes. Basically, patient who are in the stage A or B, they are the till stage A, we gives a curative treatment, and in select patient with the BCLC stage B, transplant is a offered treatment. But as you proceed in the BCLC stage C or D, so the chances or the outcomes are very poor. Next, please. So this I just was stating that how the evolution of treatment was there in the advanced and unresectable hepatocellular carcinoma. Initially, we had this drug that is sorafenib, and almost decade down the line, we have two drugs, that's the lenvatinib and pembrolizumab. And there were a lot of initial phase 2 studies with the pembrolizumab, but we did not have very consistent outcome results with that. And in 2020, we have this Embrave 150 trial, which showed that atezolizumab and bevacizumab, when compared with the sorafenib, had some better outcome as in those patients. And the next other oral TKI was the regorafenib and cabozantinib. And in second line, we have also a drug ramucirumab, which was again a patient with a high FP level. And now 2 years back down the line, we have this dual combination of IO, that is tremelimumab and durvalumab in the patient with the unresectable advanced hepatocellular carcinoma. Next slide, please. So based on this SHARP and REFLECT trial, these were the two main studies which proved that the TKs, whether sorafenib or this lenvatinib, they were used. And if you see in the SHARP trial, the median OS was 10.7 months with the sorafenib was 7.9 months. And response rate was not very much different with each other. But this was a trial which supported that sorafenib can be given to the patient in the advanced setting. But with the lenvatinib, which was a non-inferiority trial initially, designed in a non-inferiority trial, and it showed that lenvatinib had a better outcome as compared to the sorafenib. Next slide, please. So now coming to this anti-VEGF and immune checkpoint inhibitors, that is the EMBRAVE 150 trial. Next slide. So this was a phase 3 study which evaluated this atezolizumab plus bevacizumab versus sorafenib in first-line advanced metastatic, this unresectable hepatocellular carcinoma. So key eligibility criteria was all like unresectable, advanced, and no prior systemic therapy. And stratification was basically on the formula regime, that is Asia versus rest of the world. And Asian population, the Japanese was not included. And patient had a macrovascular invasion or extrahepatic spread. Based on this, whether they are present or not, and based on the alpha fetoprotein levels. So randomization was done in 2:1 with the atezolizumab and bev and sorafenib, and until loss of clinical benefit or unaccepted toxicity. And co-primary endpoint were the overall survival and the progression-free survival. Next, please. So if you see in this graph, the patient who received this combination of atezolizumab plus bevacizumab has showed improvement in the median overall survival and PFS in patient with the unresectable SCC. So in these patients at 18 months, the median OS was 52% versus 40%, and in patient with PFS was close to 24% versus 12% in those who received this atezolizumab plus bevacizumab combination. So it showed that this combination was better as compared to the sorafenib. Next, please. So in the subgroup analysis, you can see this combination of this atezolizumab and bevacizumab has not shown significant improvement in the non-viral subgroup. So you can see that patient with the hepatitis B and hepatitis C, they had some benefit with, but with the non-viral, this was not a favored combination. Next slide. If you, in regards with the toxicity and safety profile, that atezolizumab, the most important complication was hypertension and proteinuria. But if you take into TK, that a lot of side effects starting from the HFS, diarrhea, and or decreased appetite and hypertension. So of course, sorafenib was associated with a more severe side effect profile as compared to the atezolizumab plus bevacizumab. Next, please. So now coming to this trial, that's the Himalayan trial, which showed there's a dual IO, this tremelimumab and this durvalumab. That was a drug of treatment. Now it's a category 1 recommendation as per NCCN also. Next slide. So why we are combining this immune checkpoint inhibitors, that what initially it was discussed regarding in the same for the lung also, because anti-CTLA4 and this anti-PD-L1, they work in synergism with each other and they have advanced anti-tumor activity when they are combined. Next, please. So this combination increases anti-tumor activity by reversing the T cell exhaustion and allowing T cell activation respectively. Next slide. So other question was, could a single dose of this tremelimumab with durvalumab improves this immune-mediated clinic activity in SCC patient while minimizing toxicity? So this question was answered by a study 22 in which we got this answer, and we came to know this tried regimen based on this, and it was shown that high dose this T combined, that is a tremelimumab with the durvalumab, results in an initial burst of the peripheral T cells in patient with the NSCLC. Similarly, in melanoma also, the initial dose of this ipilimumab plus nivolumab causes a proliferation. So it was thought that patient who received this dual IO, there is a more robust T cell at the tumor level, and maybe this drives the benefit towards those patients. Next slide, please. So this study, which I just quoted, that study 22, from which we got to know this about stride regimen, you can see there are 4 parts of these studies. Initially, in which this T75, that's tremelimumab 75 milligram in first dose plus durvalumab every 4 weekly, and other was the durvalumab in 1500 milligram and another dose of T750 that was there. But we could not get the best outcomes other than the T75 and durvalumab. Even the combination of durvalumab, that is 1120 milligram plus bevacizumab dose was also tested, but the outcome was not good as compared to the T75 plus durvalumab. Next, please. So this study showed that steroid regimen, that is a durvalumab every 4 weekly and trilimumab 75 milligram dose, starting just of one dose, it compared, and it has a better highest efficacy as compared to the other drugs. So the longest median OS was seen in study 2 at 22 with this steroid regimen, and the median OS with the steroid arm was more than 3.6 months longer than the other treatment arms. And one event was observed at 27 months with the steroid arm, and this steroid regimen demonstrated an unacceptable safety profile and no new safety signals were observed. Next, please. So this Himalayan trial was phase 3 randomized open label multicenter study of this tremelimumab and durvalumab as a first line therapy in a patient with an unresectable hepatocellular carcinoma. Next slide. So you can see the patient again with the inclusion criteria of the BCLC stage B or C, no prior systemic therapy, and ECOG performance status 0, 1. The patient was randomized in 1:1:1 trial in 4 arms with the steroid regimen that durvalumab 1500 milligram every 4 weekly and tremelimumab 300 milligram single stat dose. Arm B was a durvalumab 1500 milligram every 4 weekly. Arm C was sorafenib, and arm D was, that is, continuation of tremelimumab 75 milligram every 4 weekly for 4 doses, along with the durvalumab, and then followed by durvalumab maintenance. And the static question was based on the whether macrovascular invasion or etiology of the liver disease, whether viral or non-viral, and performance stated, that is either 0 or 1. And with the primary endpoint was the overall survival, and secondary was the overall survival in the arm A versus arm D, overall response rate, disease completion, this duration of response, PFS, and time to progression, and the health related quality of life index. Next, please. So we have seen that a single priming dose of this tremelimumab, that's 300 milligram, and plus one dose of durvalumab followed by every weekly 4 weekly maintenance, that showed a better result as compared to what we were expecting with the arm D. Next, please. So these were the baseline demographic characteristics, and they were well matched in all the arms of this trial. Next, please. And the subsequent second line anti-cancer treatments, if you can see, it was mostly the sorafenib arm which received the subsequent immunotherapy up to the tone of 17.2%. Rest all the things were almost similar. So subsequent cytotoxic therapy was almost higher again in the sorafenib arm. So other things were, that is other form of targeted or anti-angiogenic therapy, they were almost similar in all the arms. Next, please. So this trial demonstrated statistically significant improvement in the median overall survival versus sorafenib, and patients who have received this regimen had 22% lesser death risk compared to the patient who have received the sorafenib. So median overall survival was 16.4 months with the steroid regimen versus 13.8 months. And again, if you see at 36 months, that's 3 years down the line, the patient who received this steroid regimen, the OS was 30.7% versus 20.2% with the sorafenib. There's a difference of almost 10% in those patients who were receiving this durvalumab plus tremelimumab 300 milligram at the first stat dose. Next slide. So coming to the subgroup analysis, you can see again the patient in which initially we see that's IMBRAVE trial, this the non-viral etiology was not favored, but if you see in this, even the non-viral etiology was favored patient who receiving this durvalumab plus tremelimumab. So all the things were favoring except hepatitis C, which was contrast to those patients who receive sorafenib sharp trial. The patient with the hepatitis C, they tend to do better as compared to the other patient, but in this hepatitis B or other non-viral, they have a better outcome with this T's 300 plus durvalumab combination versus sorafenib. Next, please. So coming to the overall response and duration of response, which was higher with the steroid regimen compared to the sorafenib, you can see the overall response rate was close to 20% the patient with the steroid, and it was 5% the sorafenib. And again, the median duration of response was 22.3 months in the STRIDE, and it was 18.4 months with the sorafenib. So all these data showed that the combination of durvalumab plus trivalumab was better than sorafenib. Next slide. So coming to the adverse event with respect to this dual immunotherapy, so you can see that any grade 3 or 4 adverse event was seen in approximately 50% patient who are receiving this dual anti this IO. So and with the sorafenib it's again in 52%, and any serious adverse event leading to death was more in the dual IO as compared to the sorafenib, and immune mediated again it was higher with this patient who receiving durvalumab plus tremelimumab as compared to the sorafenib. Next. So again, the patient who received this STRIDE, it was more mediated to immunotoxicity, that's a rash, pruritus, or diarrhea. But if you see with the sorafenib, that was the conventional side effects which we're seeing of this PP, that hand-foot syndrome, hypertension, diarrhea, rash, they were all the conventional side effects. But in considering with this dual, because we are of course concerned with the cytokine storm syndrome, and we are still a little bit reluctant. But single dose, I think, is still a better option rather giving a 4 doses. And again, it has shown a better outcome and less toxicity as per the study 22. Next slide, please. So again, coming to this treatment-related hepatic or hemorrhagic SMQ events. So it was seen that patient who received this T300 plus durvalumab, this was almost less as compared to the sorafenib. Next, please. So now we have update of this. This is 5-year overall survival data in the patient by tumor response from this Himalayan trial. Next slide. So again, it has been shown that patient down the line 5 years, if you see the patient who receiving this durvalumab plus tremelimumab, the 5-month OS was 19.6% versus 9.4% with the sorafenib.
Kindly.
Sure. Next slide, please. So again, this subgroup analysis also favors that dual this IO is better than the sorafenib. Next, please. Next slide. So this was again an important gradient, this LB. So based on this LB grade 1 or grade 2 or 3, so both subset of patient, whether it's a grade 1 or grade 2 or 3, this dual IO is better than the sorafenib in those patients of the hepatocellular carcinoma. Next slide. Next slide. This I just evaluated that irrespective of the LB grade, it is a better. So NCCN also recommends this is a category 1 recommendation in addition to the atezolizumab plus bevacizumab. Next slide, please. So to conclude this, SCC, one of the two most cancer affecting the Indians, and the shift from the viral to the non-viral, it is one of the most common concerns now. And this STRIDE regimen, and this showed a sustained OS benefit versus sorafenib. And this regimen has maintains tolerable safety profile in both the LP groups, and there was no additional safety concern. And it seemed to benefit across all subgroups, including the non-viral etiology. And STRIDE continued to set a new benchmark in unresectable hepatocellular carcinoma with 1 in 5 patients live at 5 years. So STRIDE and durvalumab monotherapy represent potential new preferred treatment option for patient with the unresectable hepatocellular carcinoma. Next slide. I think this concludes my study. Thank you. Thank you. So we can discuss anything regarding this.
Sir, I think in our clinical practice, most of our patients are not Child-Pugh A.
Yes.
Yes, most of the data lever side, financial things, I think most of the data regarding whether it's IO-VGF or IO, I mean, it is mainly in Child-Pugh A.
Yes.
So I think
Pranshu, I will tell you that even in the landmark, this reflect trial, if you see, we don't have the patient with the B or C type.
Yes.
But the real world, we always get the patient less of B, more of C, and still we treat. And in this, with the dual IO, we are having a clear evidence of phase 3 data of BCLC C, B, and C. And moreover, our patients who are cirrhotic, they have a varices. We are sometimes reluctant to use the bevacizumab. So this is one of the good combinations. Even I can, you have seen the slides. The patient is, you are still reluctant to use the dual IO. So durvalumab single option is a good option, good treatment regimen for those patients also, subset.
I think so. Single dose temolumab, I am not much worried about it. I think
Yes,
that
yes.
I mean, if you compare it with
This
I have,
study 22, that was a phase 2 data, and it clearly demonstrated that one dose, there was a robust peripheralization of this T cell to the tumor microenvironment. That was the reason why they used, and it has seen even in the, because Nivo-IP did the same, that's why it showed a result even in the patient who had a less of the PDL1 scoring.
yes.
So similarly in this also, this single dose, they cause a robust T cell accumulation at the tumor microenvironment, and it brings a good result in that.
Definitely, sir. I think this is the first regimen, if I'm not wrong, which is actually not targeting VEGF, but
Yes,
relying solely on immune cells.
yes, yes, yes.
So I think it should be worth trying. Okay,
Yes.
thank you, sir. I think, sir,
Thank
I
you.
would
Thank
also
you.
request you to stay for the last topic if you have, because it's
Sure,
an
sure,
interesting
sure.
topic. It is regarding the molecular classification in endometrial cancer.
So for our last talk, I would like to invite Dr. Meena Lakanpal. She's senior research scientist, Department of Genomics, National Reference Lab from Dr. Lalpath Labs, Delhi.
Hi everyone. Can you share my slides?
Good evening, ma'am.
Yes, ma'am.
I would like to thank Dr. Priyanshu for providing us this opportunity to we are able to provide you the information regarding the molecular part that we are doing every day in our lab, and for which the results that you are directly getting on the patient. So I'll be talking about the molecular classification and prognostication in endometrial cancer. Brief background, as we know, the endometrial cancer, it is the most common gynecologic malignancy with incidence and mortality rates increasing globally. And though, like the majority of the patients, they have low-grade endometrial cancer and early stage disease with favorable outcomes, which can be cured by the surgery alone. But however, there are around 20% of the patients which may have advanced stage disease or be at a high risk of recurrence and death from the disease. So, identifying these individuals to inform them of their prognosis and perform the right surgery and administer the best urgent therapies to improve their outcomes, it remains the greatest challenge. Next. This is the pathological classification. So histopathologically, like it is characterized into type 1 and type 2 endometrial cancers, and they different characteristics which are involved in this characterization. First, the histology. So type 1, they are mostly endometrioid. In the type 2, they are endometrioid, which includes the serous clear cell, undifferentiated, including the carcinosarcomas. And these the type 1, they have usually low grade, and type 2, they are usually of high grade. The hormone receptor expression in type 1, they are almost like most of them, they are positive, and the type 2, they are negative. And the prognosis as for like is concerned, so type 2, they have a poor prognosis as compared to the type 1. Next. So this classification has certain issues as it is limited as a risk stratification tools, and like histologic and the grade, they are poorly reproducible. So there were certain studies that were done, and it was found like the agreement was not that much good in the cases that were studied. And further, the inconsistent characterization, it includes not only the impact the adjuvant therapy, as well it also impacts the clinical trial heterogeneity. Next. So despite like we have done so much progress in this endometrial cancer treatment, the survival period and the quality of life of the patient with the endometrial cancer, it has like not that much significantly improved. So just to like the patients with these similar clinical pathological characteristics, so they occasionally manifest different disease outcomes. and which would reflect the molecular heterogeneity of the tumor invasion and metastasis. So there comes the role of the molecular part, like how they can be characterized into the based on the molecular the mutations or the mutational spectrum of the disease. Next. Keeping all these things in mind, so in 2013, so far, like this is the largest study, the TCGA study. It was done, and it was basically a multi-agency project. So they together like combined the data from all the genomics, transcriptomics, proteomics. So all these data sets were collected from the DNA sequencing, and apart from that, the DNA methylation reverse phase protein array together with the data from the MSI status. This all data was together compiled, and it was a multi-agency project which was initiated by the National Cancer Institute and the National Human Genome Institute. And this data was together analyzed, bioinformatically analyzed by the for the this Cancer Genome Atlas, that is a TCGA. So it has characterized the endometrial carcinoma into different subgroups. Next. So this is the mutational spectra across the endometrial carcinoma. So on the basis of the molecular classification, they have categorized this endometrial cancer into 4 subgroups. The first one is the pole E, which is like the ultra mutated. The next one is the MSI, which is hypermutated. The third one is the copy number low, which is the endometrioid, and the copy number high, which is the serous line. So all these subgroups subgroups are on the basis of the mutational spectra of the genes, which includes the pole E, the mutation in the T53 gene, the MSI status, and the TMB, like the mutation burden which is present. And then these subgroups, they were further like studied for to see the progression-free survival. So we could find a significant change in the progression-free survival under these sub categories. Like the survival was better in case of the patient with pole E ultramutate as compared to the patient, like the survival was very less as in the patient with copy number high. That is the serous line part. Next. Coming to the first group, that is the pole E mutation. So basically, in this, the pole E, we need the sequencing of the pole E gene, and the exons which are of high importance. It includes exon 9, 13, and 14. This gene, it includes the sequencing of the DNA polymerase epsilon gene, which is required for the at the time of the DNA synthesis. Around 4 to 8% of the endometrial carcinoma, they have this pole E mutation positive, and this particular subgroup, it was having the highest like the good prognosis with 98% survival in the TCGA data. So the retrospective studies with the decreased recurrence in the pole E mutated cases was done, and it tend to be the lower risk endometrioid tumors, but have found in the serous grade 3 tumors. So this is these are the common mutations that are present in the pole E gene that are identified, and any like if a patient with endometrial carcinoma has a mutation present in any of these exons, so the patient have a good prognosis. Next. Further, the 5-year disease-free survival rate was also studied for the patient with pole mutation, and it was significantly higher in comparison to the patient with which have the wild type pole. So it was 92.3 versus the 76.2, and the high antigenicity and the immunogenicity resulting from the ultra mutated phenotype and the possible hypersensitivity to the adjuvant therapy was also seen. Next. Next. Next slide, please. Coming to the second subgroup, that is the microsatellites. So as we know, these microsatellites, they are short tandem repeats, which is present in the DNA sequence throughout our genome. And if there is any error in these microsatellites, which is an result of the improper DNA repair. So in this case, like if the proper DNA repair is not done, and this leads to a situation which is called that the microsatellite instability, because the number of repeats, they are different as compared to the normal. And this particular subgroup, it is responsible for around 20 to 40% of the endometrial cancer. And the biomarkers predictive of response to immunotherapy include, which includes possibly the chemoresistance. Next. So basically, there are two ways in which we do the MMR analysis. One is by the first method is by the MSI testing, which involves the testing of the loss of the expression of MMR proteins, the MLH1, TMS2, TMS6, and TMS2 by IHC. And like the results, they are interpreted by comparing the staining status of the internal control with the tumor cells. And the second method, which involves the analyzing the 5 tumor microsatellite loci using the PCR, the fragment length analysis, or the next generation sequencing. So the different microsatellite markers they are included, and their like the stability status is checked. So next slide. These microsatellite MMR endometrial cancer accounts for approximately 80% of the endometrial cases. And these particular subgroup, it is characterized by low TMB and decreased immune infiltration compared to the POL-E mutated or the MSI tumors. The MSI low, it is defined as the like in which the microsatellite there is if the if all the markers they are unstable, or maybe all the markers are stable, but there is a cutoff in which we define a subgroup as MSI low. So both MSS and MSI low, they both are correspond to the proficient MMR group, and which is defined as a tumor cell nuclei with complete or normal expression of for these MMR proteins. However, the MMR deficiency, it is considered present if one of the MMR protein is missing, or if there is any allelic pattern shift in the presence of the MSI high as detected by the PCR or a PCR, which involves 2 or more of the 5 microsatellite markers. So basically, like 30%, if more than 30% of the markers they are showing instability, so we call it as a MSI high. So deactivating mutations in the MMR genes, it causes the genome instability, which leads to an increase in MSI and mutations. So this group comprises up to 30% of all the endometrial cancer and 13 to 30% of the recurrent or the metastatic endometrial cancers. Next. Next slide. So this is a pictorial presentation of the data that we get. So we can see the markers in which the number of the peaks they are related to the normal pattern, so they are called as stable. However, if we get the peak pattern shifted to the shifted from the normal, or we get additional peak pattern, so it means like there is a shift, either deletion or addition of the repeat is there, and it leads to the instability of the microsatellite marker. So on this basis, like we calculate
Ma'am,
how much
sorry to
marker.
interrupt you. Can you please conclude your talk in next 2 minutes?
Yeah, sure.
Yeah, thank you.
So on the basis of this, like the microsatellite markers, they are characterized as low and high. Next, please. Next. The fourth subgroup is the NSMP, that's a no specific molecular profile. So this group, it includes the endometrial cancer without POL-E mutations, the MR deficient, and the TP3 mutation. So this is specifically classified as NSMP phenotype. And in this, molecular characteristics include the low cell mutation and low copy number variations. And this histological subtype is mostly low-grade endometrial carcinoma. Next. The fourth one is the copy number high. So these are mostly the serous-like, and they account for 73% of the copy number high in the TCGA. They are serous type. This group particularly specifically have the poor prognosis. The p53 abnormal endometrial cancer, it is the most aggressive and the lethal type. So in TCGA study, the TP53 gene mutations, they can be used as an alternative to high copy number classification, and the consistency between the TP53 gene mutations and the p53 protein IHC, it is almost same. Next. So on the basis of the molecular subtype, this is just how the these like 4 subgroups, they are defined in different histological subtypes. So as we can see in this the serous type, almost around 100% of the cases they are TP53 mutated. Next. So as per TCGA, like if hypothetically we take 100 cases and we characterize them, so out of the 100 cases, if the first POL-E sequencing is done, and around 5% of the cases they are found to be POL-E mutated, and of the remaining 95 cases, when they are subjected to the MSI, check the MSI status. So around 25% of the cases they have they are microsatellite unstable, and of the 70 remaining, the T53 status was checked, and the cases with with the TP53 mutate, they are called as copy number high group, and the other one is with the wild type, they are called as the copy number low. Next, please. So this is just the presentation of these four subgroups, and we are just like here the TMB status and their prognosis and how like they are histologically related to the different subtypes. It is correlated. Next, please. So in the real-time data, this is our lab data. So around we get around 5% of the cases they have the POLE mutation, and of course 14% of the cases they have TP53 mutation. Next. So presently, like a diagnostic and the classification protocol of the easy endometrial carcinoma, they are still evolving, and the modernized and the rapid and accurate molecular diagnostic features, they certainly aid in the integration of the molecular subtype diagnosis with clinical practice. Moreover, molecular subtype are of undoubted predictive importance. Hence, it is particularly important to conduct auxiliary research on the POLE mutation, MMR, MSI, and the P53 abnormal expression to further accurately provide the prognosis and as well as the like how it can be helpful to the patient. Thank you.
Thank you, ma'am. Just one question, ma'am. I mean, what are the various techniques which we are using for testing all these mutations? And I mean, now I think we have certain panels also available which are doing all these. So, what would be
Yes,
the
sir. So
estimated TAT for that?
If we want to sequence a specific mutation type, so we have tests available for the specific variant. But apart from that, like now we have an endometrial cancer panel specific for this endometrial cancer. So we cover the TP53, POLE, and the P10 genes. And apart from that, if the clinician needs a further comprehensive panel, so we have a HRR homologous recombination repair 28 gene panel. So it covers all these three genes, and apart from this, 25 more genes are there, so they can be done. And moreover, we have a comprehensive panel available with us, which includes the combined, like all these genes are available, and we will be able to provide the MSI status by next generation sequencing. The TMB status can also be provided in that, and HRD is also given, though like it doesn't have as much direct correlation with this disease.
Ma'am, do you see that in the past probably a couple of years with the guidelines including all this testing? So do you think that this testing has increased over the last?
Yes, of course. Initially, like we were not getting that much cases for molecular part, but now with like as we have this specifically endometrial cancer panel with us, so I can see a high increase in the number of the cases for molecular classification.
Thank you, ma'am.
So
I think
yeah.
we have started based on at least in the T1A or the early cancer where you can have some clue about radiation and other EVRT versus brachy or whatever be the thing. So I think for early cancers we need all the panel genes for that, and we have also started doing this as a regular now.
Yeah, it is like if as the role of this POLE and TP53, so like which is a very important factor for a patient just to identify the prognosis and all. So it is like yes, recommended for the patients.
Thank you so much, ma'am. Thank you for this.
Thank you, sir. Okay, thank you, sir. Thanks so much.
So I think I would like to thank everybody who has participated today, and we'll see you tomorrow at 7 for day 2 of this webinar series. So thank you everybody, and Shrangi, we can conclude today's session now.
Sure. Thank you so much, everyone, for joining today's webinar. We'll meet again tomorrow at 7 p.m. Thank you so much and good night.